Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce. We'll also examine proactive approaches to cancer prevention, and most importantly, how we are breaking barriers to beat cancer in our community and beyond. Joining us today is Dr. Annemarie Hargadon, a board certified in internal medicine with subspecialty board certification in palliative medicine and hospice. As a clinical staff physician in the supportive medicine clinic, she focuses on improving the quality of life for people living with cancer. And also joining us today is Dr. Mook-Lan Iglowitz. And Dr. Iglowitz is a board-certified palliative medicine physician with special interest in helping patients and their families face their illness through planning, decisional support, symptom control, and patient and caregiver education. Thanks for joining us today, Drs. Hargadon and Iglowitz.
You're welcome.
Thank you. It's nice to be here.
Outstanding. Well, so just so we can start off, just so that we have a good understanding, can you tell us what exactly is supportive medicine and palliative care?
You know, they're actually very closely linked. Our supportive medicine clinic is a palliative care clinic. We essentially named it supportive medicine because a lot of people misunderstand what palliative care is. And so we thought in the best interest for our oncologists and our patients alike, if we name it something that's a little less scary than palliative medicine.
Yeah, that's how I start out every new patient visit, because most patients, we ask them on a survey, and most patients respond, I have no idea why I was referred to your clinic. And we put that on the survey because we suspected that might be the case, and it's a nice icebreaker. Palliate breaks down in Latin to relieve symptoms. And so we're really here to support patients who are receiving ongoing therapies for their cancer to help them feel better. And then also to address concerns they may have in this space. They have a serious illness. I say to my patients, every person who comes to the cancer center knows they have a serious illness. And we want to give them support, not only in how they treat their cancer, but how we treat the whole person.
So what exactly is palliative medicine then?
That's such a great question, Chris, and I'm so glad you asked it because I would say this is nationwide and even worldwide that people tend to equate hospice and palliative care as this very same thing, when in fact hospice is a subset of palliative care. Palliative care is for anybody at all stages of their illness who are needing help with symptom control and coping skills and just managing their serious illness. Whereas hospice is really for people who have an estimated prognosis of 6 months or less.
Another thing we hear a lot is that when it's time to think about palliative care, there's nothing else to do. And that hits at what Annie was saying. You know, palliative care is not hospice, but it also hits at this idea that palliation is, or palliative medicine is really the leftovers. When in fact, you know, real medicine is treating so many things that are happening in the patient and family when they're diagnosed with a serious illness. It's treating their emotional side of what's going on. It's addressing if there are major financial concerns. I mean, we may not be able to fix all those things, but if there are resources, our social worker can look into that and see if there's additional resources that they're eligible for. It's looking at their nutrition. So there are many things that we can do to aggressively treat their symptoms. And you know, our goal is not to treat patients so aggressively that they're incapable of functioning. Actually, it's the opposite. Our goal is to adjust their medications at the right dose so they can be more functional. And that brings to mind another myth, which is that pain medicine, aggressive pain medicine, is addictive. And that's partly true. There's a thread of truth in that. But I have many more patients that are afraid of taking a single pain medicine and actually The result is that they're not functional. They're sitting still or they're laying in bed. When with a little bit of pain medicine or the right dose scheduled at the right times, they could be much more functional and start to return to activities that they love.
Well, that sounds like that's an important conversation then for our patients to have with you to make sure that they're really open and addressing what their concerns are so that you can hear them and then you have that full discussion, correct?
Mm-hmm. Right. I had one patient that with the tiniest dose of the right pain medicine actually started playing his violin again.
Oh, outstanding.
And I always think of him because not every story is like that, but that's really what we're looking for, is helping them return to things that bring them passion or joy in the midst of a hard road of cancer.
Okay, well, so tell us just some of the services. I mean, you've mentioned about pain medicine and addressing some of the pain needs there, but what are some of the other services that you offer and that the patients have access to?
So palliative care it's an interdisciplinary team approach towards helping people live the best they can for as long as they can. And what that means is we employ all members of the team to help people live their best life. And whether that's our dietitians who have special training in oncology, or whether it's our chaplain to help with existential and spiritual concerns, whether it's our nurse and our medical assistant, who are phenomenal at helping people deal with sort of the logistical, collaborative approaches to their medical care. And our social worker, we now have a dedicated social worker in the supportive medicine clinic who is phenomenal. So with all of us together, we can help address everybody's symptoms the best possible. Pain doesn't always come from some physical ailment. It could be an emotional pain. And sometimes our chaplain or our social worker, our nurse or medical assistant, even our dietitian can help people process that. So it really is, we couldn't do it without the team.
Well, and how would a patient engage with your team? Is this something that just automatically happens, or do they need to ask, or how does that go about?
Great question. We are getting referrals from multiple directions, and that's probably how it should be. What I mean is that sometimes patients have a good friend or a family member that had a great experience with additional supportive care, meaning, a palliative care provider or team. And that person told our cancer center patient, you should ask about palliative care. So they ask their oncologist, and the oncologist submits a referral. Sometimes it's the oncology team who sees that there's a lot of maybe tensions, or it's difficult for the patient and the family to really grasp and understand what's going on, or they're struggling with symptoms and they see a steady decline. They can see ahead that this patient may or may not do well. And the concern is that they may not do well and need to get to know us, so that if they don't do well, they have additional support already engaged, and that we can step in and help. The third way is when the social workers that work at the cancer center see a patient for another reason, and they recognize that that patient would truly benefit from the supportive medicine clinic. They may reach out to the oncology team and recommend a referral.
Well, when is the appropriate time also to engage, like within the treatment schedule?
I would say that the best time to engage, and Chris is another great question. There's a lot of studies out there that are trying to examine exactly that question. And the studies kind of range. There are some that say, the best time to engage supportive medicine or palliative care is for anybody with stage 4 cancer or metastatic cancer. There are other studies that look at in terms of, about how much time do we think that person has, and anybody with a, estimated prognosis of about a year or less would be a good candidate for supportive medicine. But then there's other studies that say, hey, from the moment of diagnosis of a serious illness, it would be great to have supportive medicine. I think for us, we're happy to see anybody who wants that additional support. And I would also say that it is one of those. A lot of the studies show that, I guess this would come under the myth busting too, that people who that have palliative care as part of their team tend to actually live longer. And so that's a really important thing to take account of, is that it doesn't necessarily mean people are at the end of their illness, and for many people it helps them live longer.
Two studies that come to mind are the landmark study by Temmel et al. That showed that patients with lung cancer who were treated concurrently with palliative care did live longer.
Yes, so there is sort of a this beautiful window in which it is a perfect time to refer to palliative care. And this meta-analysis by, I think the guy's name is Herger, but we'll get that to you. And in that meta-analysis, it showed that people who were referred to a palliative care clinic with an estimated prognosis of somewhere between 9 and I think it's 3 months, 3 months to 9 months, had so many benefits. A survival benefit, a quality of life benefit. There was improvement in the quality of life for the caregivers. If people are referred to supportive medicine or palliative care with just a very short period of time left, they don't get the full benefit. If they're referred to us with 1 or 2 months estimated prognosis, it doesn't give us enough time to have a significant impact on the quality or the improved survival of their life. But there is kind of that special window, and for them it's anywhere in that 3 to 9 months range.
Would it be appropriate for patients that are newly diagnosed, if they're coming to the cancer center for the first time or something, to see their oncologist and to have just to go through all of this, to have maybe to get an initial referral set up with supportive medicine just to see what their options are? Or is that something that really they should wait a little bit longer before engaging?
I would say it depends on the stage of their cancer diagnosis. Stage 3, stage 4 cancer is very appropriate. I guess the other thing I would add is the patient may have, earlier disease, like stage 2 disease, but may have really significant anxiety that's hampering their function. That's also an appropriate referral to our clinic, just to treat those symptoms and give them support.
Okay. That's good to know. And so that way, just with them having at least an initial consultation, you're able to assess their level of need, and then you can appropriately determine how much you or they need to engage with you. Correct?
That's correct. The only thing that we ask when people are referring to us is that they're followed by a medical oncologist at UC Davis or a radiation oncologist at UC Davis. We don't follow people whose primary medical oncology is elsewhere.
Good to know. No, that's perfect. And I'm sure that other institutions have a form of palliative care, a team or a supportive medicine clinic like that. But yeah, that's a great addition that we have at the Comprehensive Cancer Center. Is there anything really that that patients, caregivers should know or should be aware of that you that maybe you're like that pop into are frequently asked, or that you see pop up a lot in the course of just your treatment with them and meeting with people, that like if you had like that wish list or that checklist of like, oh man, I wish people knew this. What are there anything like that you could tell us?
I guess what I would say to start off with, Chris, is that I would wish that people were not worried about being referred to palliative care. I would wish that they would think, oh, fantastic. I'm going to have my symptoms managed as best as they can. I'm going to have a whole team of people supporting me through this journey. I'm going to have some coordination of my care with my oncology team, and that they will still be very much the primary clinicians in my care. And so I would want them to feel happy and comfortable that they are being referred to palliative care so that they can really get the best care possible. I guess the other thing is that the reason why palliative care is kind of hard to define is that we're different things for different people. It's so individual. So for some people, it is really about managing their pain the best we can. For some people, it's that they're worried that they're a burden to their family and they hate living with that feeling. And how can they deal with that sadness? I had one patient, after we talked a little bit about what supportive medicine was. He was a mechanic, and he said, "Oh, so you're like a tune-up." So and I thought that was a great analogy. And then I had another patient who was a big motorcycle rider, and he said, "Oh, you're riding shotgun with me." And so it was just, it's kind of a different way of getting the best care that you possibly can while you're dealing with a really serious illness.
I think one of the things that we forget is that talking about advanced care planning, or talking about, what's important to the patient if they were to get sicker, does not equate with them being at that place. It actually equates with good medical care, right? We, as, physicians or nurses, we struggle because we're here to fight death. I mean, that's why we went into this profession, but that often gets confused with this idea that we can't talk about that area. I mean, it is scary. Let's be honest. It's scary to think of your own death. It's scary to think that that's something to talk about, or what are you afraid of? But also, learning about a patient in that area is valuable. It's valuable for us as providers. It's valuable for their loved ones. I mean, we might assume sometimes that everybody has talked about this at home, when in fact, many of these conversations are even more difficult at home, because the patient doesn't want to discourage the people that are caregiving for them, and the caregivers don't want to discourage the patient. And it's just hard to breach when it is a potential reality. And so, when we're fortunate enough to meet patients, when we do get that consult and they get in, it's common for them to express some hesitation about this area of talking about it. And I want them to know that this is a part of learning about you and putting your values in the chart so that we can reach for concurrent care. Meaning, if we've never explored it with you and we haven't put any notes in your chart and we haven't learned about you, an area might come up where we are uneducated about you, and we may do things that you don't want, or it's more than I want to live longer. And the conversation is more than do everything or I'm not done living. There's a lot to learn. And, we're here to support the patient, to help provide the best care possible for the patient and family, and also to put some notes, in your chart about just some core values, like kind of like a lighthouse. You don't know exactly what that road's going to look like, but if we can map out some key lighthouse points of value, then that can help guide your medical team or your loved one, maybe if they were ever in that position.
That's great. Very empowering also to the patients.
Yeah, it is very empowering. And it's funny because that is in stark contrast with the fear of talking about this, right?
Mm-hmm.
It is a scary thing to talk about for, I would say, most patients and frankly, most providers. Okay, let's be honest here. Many of my colleagues who I deeply respect and who are far smarter than me, they themselves are not sure what is palliative care. They are not sure that exploring these areas don't mean that we think they belong in hospice. There's a lot of confusion around our field. And so just breaking the ice and helping everyone to understand that this is all for the holistic care of a patient when they indeed are facing a terminal diagnosis or a serious diagnosis.
Well, is there any other topics or points that maybe we didn't cover that you would like to address that you feel is important for us to get out there?
I guess I would add one other thing is that palliative care, it's a new specialty, just what do you think, Mook-Lan, within the last 20 years, maybe it's been a board certified specialty. So it's completely understandable that people don't fully understand what it is. It is new, but if you kind of think about how it was born, how this field was born, it came about during a time of unbelievable advancement in medical technology and treatments. And the pace of those treatments was kind of faster than what we knew how to best use those treatments. And even more than that, even if we know how to best use those treatments, do we really understand what matters to people when it comes to having to decide about whether to pursue those treatments or not? And so palliative care is born in that setting and kind of in an old-fashioned way goes back to the patient and says, okay, these are all the options available to you. And in order to make the best decision possible, let's talk about who you are and what matters most to you. And from there, we can support you in this decision-making process about what treatments might work best for you and what might be too burdensome or not align with your values. And so it's a really, I love this field because it's old-fashioned and it's cutting edge at the same time.
All right. Well, thank you, Dr. Hargadon, Dr. Iglowitz, for joining us today. And we thank you for tuning in and listening. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.